and circuit tranexamic acid in the treatment of left lateral bleeding. And it was a double-blind trial with 187 participants. The tranexamic acid arm, participants received a total of 3.9 grams of tranexamic acid in a day, divided into 3 equal doses. And the non-interventional arm received a placebo. So the tranexamic acid was given for a total of 5 days, at most 5 days during the menses. So these are the results. The researchers noted that tranexamic acid significantly reduced the menstrual blood loss by about 40% versus a placebo, which they noted that there was 8.2% reduction in blood loss. So this was also, tranexamic acid was also reported to be to result in meaningful intervention by the participants themselves. The majority of the adverse events which were reported from tranexamic acid in this particular article were mild to moderate. Another article which looked at tranexamic acid intended versus for controlling blood loss during open abdominal myelectomy. It was a double-blind placebo-controlled randomized trial involving 114 women, and the arm of the tranexamic acid received 1 gram of tranexamic acid intravenously during OP, and the final outcome was the volume of intraoperative blood loss, and the secondary outcome were the mean volume of total blood loss. And what they then noted was the mean total blood loss was significantly reduced in the tranexamic acid group versus the placebo group. And the rate of intraoperative blood transfusion was 5% in the tranexamic acid group, and about a third of women in the non-interventional group needed blood transfusion. And similarly, we see similar results in terms of post-operative need for blood transfusion. So the conclusion, according to them, was combining tranexamic acid with a tonic, we see that in gynecological practice, especially in cases of huge uterine fibroids. I'm going to project this. I will start with levonorgestrel intrauterine system, which is a t-shirt polyethylene film that uses levonorgestrel. Initially, it was approved for contraception. However, in 2009, it was FDA approved to treat menstrual bleeding. In the commonly cited in literature is the one which contains 52 milligrams of levonorgestrel. And it is replaced after every 5 years to ensure that it's to ensure its efficacy. And its mode of action, it stabilizes endometrial fragility and the endometrial volume, and as well inhibits angiogenesis. Various studies have looked at the benefits of the efficacy of progestins of levonorgestrel intrauterine system in improving left menstrual bleeding. And it has been noted that it reduces left menstrual bleeding by more than 90%, and also reduces hemoglobin and ferritin levels. However, it does not affect the size of the uterine fibroids. Adverse effects are abdominal discomfort and weight gain. I'm just going to talk about oral progestins. They stabilize endometrial fragility as well, inhibit endometrial growth, as well as angiogenesis, and they stimulate conversion of estradiol into the less efficacious estrone. They also prevent ovulation and reduce ovarian steroidogenesis, interrupting the production of estrogen receptors, as well as the estrogen stimulation of the endometrium. So some examples of the oral progestins are progesterone acetate, norepinephrine, progesterone acetate, and nitronized progesterone, which can be given cyclically or continuously to reduce menstrual blood loss. So one of the common ones which is prescribed is norepinephrine, which has been noted to reduce menstrual bleeding by more than 50% if used over 6 weeks. So the use of oral progestins to treat uterine fibroids has not been strongly supported by evidence in literature. And FIGO recommends that it can be selectively, it can be given in selected cases. For example, women who are presenting, who are having menstrual bleeding as their main presenting symptom, and they also require contraception. However, we see that it's quite often prescribed for treatment of uterine fibroids owing to the low cost and as well a low profile of side effects. However, they also do not reduce the size of the uterine fibroids. So I'm just going to describe a few articles about the uterine system and oral progestins. So this was a systematic review which was published in 2020. The aim of this review was to determine the effectiveness, acceptability, and safety of progesterone used in intrauterine devices in reducing heavy menstrual bleeding. It included 25 randomized controlled trials, and the placebo group, there was a comparison with the placebo group, other medical or surgical therapy for heavy menstrual bleeding. And these are some of the medical therapies: episteroid, hydroxyprogesterone acetate, combined oral contraceptives, mefenamic acid, and tranexamic acid. So the results were that compared to no treatment or other treatments, levonorgestrel intrauterine system lowered menstrual bleeding by about 67 units. And it also resulted in improved count of lung. So levonorgestrel intrauterine system and other medical therapies with similar adverse events. However, they noted that the use of levonorgestrel intrauterine system was associated with better compliance compared to the other medical treatments. Another article here, which was a randomized controlled trial with an aim to compare the effectiveness and the acceptability of the levonorgestrel intrauterine system with the norepinephrine in achieving reduction of the volume of myomas, hemoglobin levels, and satisfaction of women. And the treatment, one arm had levonorgestrel applied in the first 10 days of the menses, whilst the other comparative arm was oral norepinephrine 5 milligrams twice a day from day 5 of the cycle up to 25 days. And one of the significant findings was that visual blood scores were significantly reduced for the levonorgestrel arm versus the norepinephrine arm. So blood loss was less than half within those participants who were given levonorgestrel. And as well, in terms of hemoglobin levels, there was a significant improvement in hemoglobin among the levonorgestrel arm by 17%, versus 7% within the norepinephrine group. Estrogen progesterone contraceptives they primarily work by ovulation, and they also reduce abnormal uterine bleeding. There's no evidence to suggest that combined oral contraceptives promote the growth of uterine fibroids, given that they contain estrogen, which theoretically may stimulate the growth of uterine fibroids. And there's limited evidence on efficacy of other fibroid-related symptoms, such as pressure symptoms, pain, and so forth, rather than evidence available for heavy menstrual bleeding. And women with uterine fibroids who use hormone replacement therapy must be periodically examined, and the normal treatment is continued if fibroid size is increased, despite the previous pattern that I have just alluded to. So this was a systematic review This slide is showing results of the systematic review, which was conducted to determine the efficacy of combined hormonal contraceptives compared with other medical therapies, placebo, or no therapy in the treatment of breast instability. And there were 8 studies in 805 participants. So, one arm, the treatment intervention arm, that received either combined oral contraceptive or vaginal ring with combined progesterone and estrogen, taken for 3 weeks during each cycle. And the results showed that women or participants who received combined progesterone and estrogen returned to complete menstrual normality more versus those who did not, with an odds ratio of 22. And we also see that there was women who received combined progesterone and estrogen had at least a 5 times improvement in terms of menstrual blood loss within 6 months of administration. I'm going to move on to gonadotropin and releasing hormone analogs. I'll start off with agonists, which have amino acid substitutions that enhance their affinity to bind to the GnRH receptor. And the agonists, they initially gave a flare of the gonadotropins within 1 to 2 weeks of administration, followed by castration of the steroid levels. And they are very effective in terms of shrinking the size of the uterine fibroids by about 50%. And they also reduce the size of the uterus. And they also increase the hemoglobin, which may be beneficial pre-operative. So a couple of articles I'm just going to show you a few after this slide have reported that the result in reduction in blood loss, reduced the need for blood transfusion, gives low odds or smaller odds of receiving a vertical infusion during surgery for myomectomy or for hysterectomy, and as well lower odds of difficult surgery and improved post-operative hemoglobin. So the duration of their therapy is really limited by adverse effects, especially the menopausal effects, which include both flushes, headaches, and so forth. So because of those adverse effects which I've talked about, they are generally restricted to a 3 to 6 months interval, unless different ending therapy is used, which can then make them extended to a maximum of 2 years. And it's important to note that upon discontinuation of the GnRH agonist, the uterine fibroids will come back to their peak in France. And there has been a meta-analysis which was published in 2020, which did not find benefit to hysteroscopic myomectomy with regards to complete resection of submucosal fibroids, operative time, or absorption of the fluid media, and as well complications amongst patients who were given GnRH agonists. So based on that, routine preoperative use of GnRH agonists is not recommended prior to hysteroscopic surgery. Looking at antagonists, they bind reversibly to the GnRH receptors, but as opposed to the agonists, they do not meet the flare effect. And the result in medical castration area within 24 to 72 hours compared to up to 2 weeks, which were seen with the agonists. An example is the L-agonists, which can be given at doses of 600, 400, and 200 milligrams, and is effective in suppressing bleeding, but it's got a greater likelihood of giving amenorrhea, especially if it's administered without an active therapy. So a reduction in menstrual blood loss, it results in reduction in menstrual blood loss and as well improved quality of life scores. So based on this, what I've just said, anabolics, another example, given as a fixed dose combination with estradiol or androstenedione, if FDA approved for the treatment of uterine fibroids related to uterine fibroids related to menstrual bleeding. GnRH agonists and antagonists have got comparable reduction in fibroids size and as well uterine volume, which and also hemoglobin concentration, hemoglobin levels. Lastly, I will talk about progesterone receptor modulators, which are known to reduce the growth of uterine fibroids and improve symptoms. And improvements in fibroid symptoms is a rate of quality of life, in addition to menstrual blood loss and higher rates of amenorrhea was reported in a number of articles. And they give comparable results with the GnRH analog with regards to improvement of quality of life and as well other symptoms such as pelvic pain. An example is unicristol acetate, which is the only progesterone receptor modulator which was approved for the management of uterine fibroids. And it is strictly restricted as a result of, it has got a couple of adverse effects, but one of the serious ones is liver injury, which in some cases even resulted in requiring liver transplant. So it is not in use in the United States, but it's approved for use in Europe, where it is approved for specific conditions, given that there is no risk of liver failure, and there is also an allowance to monitor the liver function during administration. So some of the benefits are that it shortens operative times, it reduces fluid absorption during the hysteroscopic myectomy, as opposed to the analogs that we talked about, and it is associated with endometrial changes, which are termed unicristol acetate endometrial changes. However, these changes were found to be benign and not pre-cancerous. This slide is showing an article of a systematic review with an aim to assess the effectiveness and safety of medical treatments prior to surgery for uterine fibroids. It was published in 2025. It included 38 randomized controlled trials, and it compared medical therapy versus the placebo, no treatment or other treatment therapy before surgery. And the various medical therapy options which were analyzed in this particular trial were GnRH analogs, progestins, selective progesterone receptor modulators, selective estrogen receptor modulators, specifically loxapine, dopamine agonist, cabergoline in this particular case. So the results of this study were that GnRH analogs reduced uterine and fibroid volume significantly compared to a placebo by about 175 mils for the uterine size and 6 mils for the fibroid size. And it also increased the preoperative hemoglobin levels by about 1 gram per deciliter. And there was a greater likelihood of adverse events, especially hot flashes related to GnRH analogs. In terms of respiratory time, it reduced it by about 10 minutes, and this was significant. And there were fewer post-operative complications, specifically infection and bleeding. So GnRH versus other medical therapies, GnRH was associated with a greater reduction in uterine volume by about 47% versus 20% to 22% with either 5 milligram or 10 milligrams unicristol acetate. However, this was at the expense of those adverse effects, especially the hot flashes. Excessive bleeding was controlled rapidly by unicristol acetate compared to the GnRH analog, and all the other benefits that I've talked about with regard to GnRH analog were comparable to the selective progesterone receptor modulators. And with regards to carbidoline, there was no difference in terms of the reduction of uterine fibroid between GnRH and carbidoline. This is a premier study which was published a couple of years ago with an objective of assessing the treatment with unicristine acetate in a pre-operative setting, and it was conducted in Europe. 75 centers within 10 countries. They enrolled 1,473 participants, and the participants received 5 milligrams of unicristine acetate once a day for 3 months, and they were followed up at 3 months intervals, up to a maximum of 15 months. And the results noted that there was a 61 to 88% improvement within these women who received unicristine acetate, and a total of only 39% of patients underwent a surgical procedure, leaving 42% having an option of not being operated because their symptoms had actually improved. So the conclusion was that using unicristine acetate prior to surgery, one will actually delay or even avoid surgery because the unicristine acetate lasting improvements even months following withdrawal of the unicristine acetate. Okay, so this is just a summary of another study which was conducted in Canada, which concluded that, so in this particular study, it was a retrospective cohort study, which had 2 gynecologists reviewing surgical videos of women who underwent laparoscopic myomectomy, comparing those who received unicristine acetate and those who did not. And they concluded that unicristine acetate does not disturb the surgical plans in patients who had undergone myomectomy for the removal of uterine fibroids. So I won't go through this. It's just giving us the summary of what I've talked about. All the medical options which I've talked about, the resulting reduction of menstrual blood loss. However, a few, that is the GnRH analogs and selective progesterone modulators, result in the reduction of uterine fibroid volume, hence improvement of the other symptoms apart from menstrual bleeding. After having said all that, what are the various guidelines saying about use of these medical options? So this is the recommendations from the NICE guidelines in 2021. If the uterine fibroids are less than 3 centimeters in size and no endometrial distortion, one can prioritize the levonorgestrel intrauterine system, or can consider tranexamic acid or non-steroidal anti-inflammatory drugs, C-O6, norepinephrine, or hysteroscopic myomectomy for submucosal fibroids. If they are more than 3 centimeters, these are the options. And NICE, as I have said earlier on, they approved use of unicristine acetate in the as an option for the management of uterine fibroids. As opposed to NICE, these are the recommendations from April 2021. If a woman is not a candidate for surgical management or does not requires medical management, the first line is an oral GnRH antagonist with an therapy for up to 2 years. Apart from that, one can consider a 52 milligram levonorgestrel intrauterine system or tranexamic acid. If it's a surgical candidate, this myomectomy or hysterectomy can be offered. So this is just concluding. The majority of clinical evidence that I've presented is from high-income regions, and it actually encompasses within the guidelines high medical options with high cost, and this leads to economic barriers. In many low to middle income countries, the options remain as the hormonal, the oral progestins, tranexamic acid as the mainstay of medical treatment because of the cost. What are some of the future options? So there's a phase 3 trial, which is looking at the SHR7280 use in persons, in people with left menstrual bleeding from uterine fibroids in China, which, so SHR7280 is a GnRH antagonist, which is a non-peptide antagonist. So in terms of the benefits, it's similar to the antagonist that I've talked about. However, this one was proved in the phase 1 and 2 to be beneficial or to be better in terms of the side effect profile, especially the mucosal side effects which I've talked about. Other options which are being researched on include vitamins and other dietary supplements is adjunctive treatments for uterine fibroids. In conclusion, pharmacological treatment constitutes a key component in the management of uterine fibroids, and the choice of therapeutic agents is guided by the patient's predominant symptoms and overall clinical profile. Global access to some agents remains a desirable goal to find more cost-effective therapies. Thank you.
Dr. Duayo for the scientific presentation. I think it's now ready for the exams.